Hola, ¿qué tal? Muy buenos días a todos. Bienvenidos a este
Good
seminario web.
morning to all of you. Welcome to this seminar on the communication of information. We are going to allow for an extra minute or so to allow for extra participants to connect. We will be starting in 1 or 2 minutes. Thank you all for connecting.
Bueno, ahora sí, si les parece, vamos a ir comenzando.
So we're going to start now. Welcome. And thank you all for connecting today to this webinar that we are hosting here at PAHO on the verification of information. The seminar will last about 1 hour and a half, and we will have interpretation into English. So please just click on interpretation and choose English. I would like to thank first the work that we have been doing over the last year on the verification of information, Chequeado, and also on the development of this guideline that we are presenting today. For those who are not familiar with Chequeado, Chequeado is an organization that is working on counteracting fake information and also contribute data to the public discourse and the public discussion, and we will hear from them soon enough. And I would like to share with you what we will be discussing today. As you know, we are presenting this guideline with advice on how to verify information on COVID-19 vaccines, but at the same time, this can be also adapted to other disinformation. We have the guide available in English, French, Portuguese, and Spanish, and you can find it on our website. And if you want, we can send you the link. It is, you can quickly see the contents of the guide here. We are going to be addressing this today with our panelists. We are going to talk today as to how information spreads, the reasons behind disinformation, and also the most common pieces of disinformation that we have seen during the pandemic, and also some evidence and how we know what we know. Why this guide? Why did we decide to work on the verification and disinformation? Because of the infodemics that led us to see it more frequently during the pandemic. This is not something new, but it was quite frequent during this crisis, and also because the infodemic meant that the pandemic was more difficult to control and contain. We also need truthful information to help people reduce the risk for their health and also to avoid the spread of diseases and viruses. And we also know that truthful information saves lives. And also because this is addressed to the media and journalists. We know that they are our partners. They were our own partners during the pandemic. They are partners against disinformation, and they have a key role during health emergencies. In this image, you can see in this graph how disinformation spreads, rumors, and also how we cannot stop it. If the person stops sharing rumor, or if another person does not share something that is not trustworthy, that is a way to stop the spread of disinformation. And I think that if the information is not shared, whenever it is not checked or verified, you can also help curb the spread of fake information. What are we going to have today? Our agenda today includes a presentation on the situation of routine vaccination and also COVID-19 vaccination in the Americas, also the latest recommendations we have. We are going to present a general overview, and then we are going to look into verification. We are going to have presentations as to how disinformation spreads and also the role of the communicators and the most common situation we have seen with the vaccines. And we'd like to go beyond with this webinar. We'd like to see how to prepare us so that we can better address the next crisis, and also how to responsibly communicate on these health issues. Who will be presenting today? We have Dr. Daniel Salas, who is the Chief of Immunization here with PAHO, also Florencia Ballarino, who is with Chequeado, and also a member of the board of directors of the Argentine Network of Scientific Journalism, and also Olivia Sort, Director of Impact and New Initiatives, and she's one of the authors of this guide we are presenting. We invite you to use the chat and the Q&A buttons to ask us questions, and also at the end of the presentations, we will be addressing questions, but if you have any comments or if you'd like to share your own experience, we will be reading and sharing with you. So please feel free to share. But now, without further ado, I would like to invite Dr. Daniel Salas, Chief of Immunization with PAHO, to start with his presentation. Dr. Salas, you have the floor. I thank you, Sebastian, and we are going to look into vaccination and health emergencies that we have active currently. We're going to see how we are doing in the Americas in general. This is a look at the general vaccination situation, and this picture is not just random. When we're saying that vaccines save lives, this is something that we may have forgotten, but it is important. We have achievements, and the Americas was a region that opened up the field and taught the world how to eliminate many of the viruses that are currently, again, threatening with attacking us again. And when we are saying that vaccines save lives, I think that this is key. And fortunately, we did not have to have polio outbreaks, kids, children that died due to measles, which was the norm in the past, and vaccines save lives, and we may have forgotten that. And we don't have to face polio consequences anymore. This slide shows us a trend line. You can see that from 2020 to 2021, the various regions in the world are organized according to WHO, and you can see here that the purple line is the line of the Americas. This is what they call UMRO. And you can see that in 2000, we were almost first in the ranking of the areas that had the most vaccination. Here you can see the areas that have the third dose of DTP. This is one of the vaccines that we use the most to assess the progress made in vaccination. And you can tell that our goal in the Americas is to reach 95% or higher. And right now, you can see that the cases by PAHO and UNICEF, this is at 80%. And what has happened with the Americas? That is the big question. What has happened with the vaccination programs? And you can tell that this represents in 2021, 2.7 children younger than 1, that is to say 19.7% of these children that did not receive all of the vaccine doses. These kids are vulnerable to severe diseases such as tetanus, measles, diphtheria, and you can see the horizontal color bars that you can see at the bottom of the graph. And in 2020, you had other 2.7 million children that were under-vaccinated. So if we go to 2019, you have an additional 3 million, and if we look at different years, you have to keep adding millions of children that are not vaccinated. So this requires a very integrated effort among the various sectors. This goes beyond health sector. As we have seen with COVID, these are diseases that have an impact on all of the sectors, on all of the segments of the population. This is key to understand what has happened in the world and in our region in particular. Then, when we break down the various types of vaccines, some vaccines protect against different viruses. This is a vertical bar graph that shows us a summary of the situation between 2016 and 2021. This is not a trend for BCG, that is the vaccine that protects against tuberculosis or measles, mumps, and rubella. You can see that the trend is similar. There continues to be a concern because it is not just one disease that is making our children vulnerable, but more than one. And at this point in time, I would like to mention to you that if you know of any acquaintance that has stopped vaccinating their children, think of a friend, a family member that because of the pandemic said, I am afraid to leave the house, then the vaccination schedules for children are lagging behind. Bear that in mind. What we are seeing right now is becoming more and more frequent. Let's move on to the next slide. These two graphs show us the number of children to the left of the screen that have not even a single vaccine in 2021. That accounts for 14% of all of the children in the Americas. That is the rate of unvaccinated children in the Americas. And you can tell that there are some countries that because of the number of children and also the extent of the population and also the birth rate, that accounts for a greater rate, such as the case of Brazil, Venezuela, Mexico. But what is the other side of the coin? We see that the 14% of the children or 19% of the children that have not been vaccinated, we need to add an additional 5% to follow up. That is to say, you already identify the child because one or two vaccines, depending on the vaccine we are referring to, may not be enough to protect, for the defenses to be strong enough to say that the child is properly protected. So the one on the right tells us that an additional 5% of the unvaccinated children are under-vaccinated. So we end up with 19% of children that are not vaccinated in the best possible manner. And this is using DPT-1 and DPT-3. So if you look to the left, the countries that are there represented are also represented to the right, but we see that the percentage increases in some countries and for those that were represented on the left. All of this takes us to the situation of the current pandemic, whereby the vaccines became key actors. You can see the number of cases that were confirmed here in the Americas this year, 178 million of confirmed cases. It is an incredible number of cases. And you can also see the number of deaths. We're talking about 2.8 million people over a 2-year period. This is an incredible number when we compare this to the other diseases, to the other situations, diseases that may lead to death. COVID is a record disease, and please accept my condolences because I know that there are individuals here connected today that have experienced the loss of a family member or someone close to them. But there is something important here, vaccines. And here we see the progress made in terms of COVID-19 vaccination. The number is record here this is a record number here in the Americas. If we start to vaccinate we started to vaccinate in 2021 on a continuous manner. We have been during a pandemic over 2 years, but we started to have the possibility to have access to vaccines that is a little bit over a year and a half. So we see that we have there 2 billion vaccines that have been administered in the Americas, an incredible number. And also the effort by the countries has been incredible. We also see to the right, 70.1% is the rate of vaccinated individuals with full schedules in the Americas and in the Caribbean. And that is a percentage that, according to the WHO, is the minimum threshold. And we attained that already in the Americas, but that also takes us to the next topic. And we see that there are still 210 million persons who have not received not even one single dose of the vaccine in the Americas. And among those 210 million, it is important to understand that there are individuals that are susceptible to severe disease and to death. So we still have an important debt, 210 million people that we still need to vaccinate. And when we look at the percentage, I would say that as a region, we have already overcome that threshold. But when we look at the overview, we see that the situation is not as even as we would like. We have 16 countries that have already overcome that threshold, the 16%, the population that can get vaccinated. But we see an important number of individuals, 70, an important number of individuals that are, or countries that are below 70% and even 40% of the vaccination threshold, in particular in the Caribbean. But that 70% threshold has been reached in most countries. There you can see some variance in the colors and of the bars, and it shows these are the reports we receive from the countries. We also see that some countries have stopped sharing their information on the numbers of vaccinated individuals. And this other graph tells us that as of October last year, the countries and territories of the Americas are administering. You can see here the light blue bars, primary doses, that is to say, full schedules. And as of October 2021, we started to see that the country started to progressively vaccinate with more boosters. I am not saying that this is bad. We need to attain that, in particular among the most vulnerable individuals. They do need to have their boosters. But this graph also shows us that the number of individuals that have 0 dose is not decreasing. And we have seen that already, 210 million individuals. But when we do the week-to-week follow-up, we do not see a significant reduction. That is to say, the countries have focused more. And I know that there have been several barriers to get to some percentages of the population with some primary doses and with the full schedule. But what this is telling us is that we need to try to have those light blue bars grow. So this has been a very important challenge to reach those thresholds, but whatever we do with those 210 million people, there are many individuals among those that do have underlying diseases that may end up with the death of these individuals. This is the breakdown of vaccination coverage by subregion. Here in the Americas, you can see how we try to divide it into full schedules. That would be the light blue bars that have at least 1 dose. These are the percentages in orange that shows at least 1 dose, and then in gray 0 dose. So you see that the southern cone is the one that has the highest rate, the highest coverage, 78.9, followed by the Andean region, then North America, and the Central America 58%, and then the Caribbean between 40 and 52%. And so we see how this is increasing also in terms of unvaccinated individuals. This is the graph to the left. Now, on the right, what we see is the breakdown based on income levels. So we took all of the countries and we see the income level. The countries that have the highest income have barely more than 70%. And when we look at the countries that have a lower income level, middle income level, we see that their performance has been a little bit better with the full schedule, not so much with the booster. But when we start having lower income, we see a significant reduction. When we look at low-income countries, 47.7%, that is quite low. And that should also be a call to try to understand what happens in these countries in terms of vaccination, and also in connection with the pandemic that implied that they would have lower coverages as compared to other countries. We do know about vaccine access. Higher income countries did have access sooner than others. Now, to conclude, I would like to refer to COVID-19 vaccination and boosters. The individuals that have not been vaccinated do need to receive the full schedule. When we're talking about AstraZeneca, Pfizer, or Moderna, the basic schedule starts with 2 doses. So when we're talking about boosters, that is to say, the immunological system already has a basic defense level, then we do need the boosters. So when the immunological system starts to decrease in terms of its capacity to protect itself, the booster fine-tunes the system. So we know that the highest priority is for 70% of vaccine coverage with the primary series is attained. And when we're talking about the high-risk groups, we would need 100% of those individuals to be vaccinated with the first doses and then with the booster. We have 4 bivalent vaccines with the mRNA. And what does it mean that they are bivalent? That means, or bivalent, that means that they do have the component of SARS-CoV-2, the virus, but also they have included the Omicron variant that is the one that has caused the most problems, that is the prevailing one. And you see there BA1, BA4-5 in combination with that ancestral virus. And it is important because current evidence tells us that these bivalent vaccines that have been available for a very short period of time may not be used as the primary dose. The primary dose should always use the original vaccine, the one that was used in 2021, then in 2022 for primary doses. SAGE, that is the highest ranking group in terms of vaccine advisory services, indicate that the vaccines available are not enough, or the data available is not enough to recommend the booster for the bivalent vaccine. What it's telling us is that for those individuals that do need a booster, they need to use the vaccine that is available in its original form or the bivalent form. It doesn't matter which one it is, but the booster needs to be applied when needed. And this is clear. And now as to children, we see that children may be vaccinated starting at 6 months, and this is by using the pediatric version of booster of the Pfizer and Moderna vaccine, so they can be vaccinated starting at 6 months, and then also children and teenagers younger than 18 years of age with comorbidities should also receive all of the COVID-19 vaccine doses. I know that some of you are going to ask me, we heard that children do not get sick as frequently, but it doesn't mean that they never get sick. So there is we have seen a multi-systemic syndrome that only affects children, and we have seen also children with severe situations in the emergency rooms, in intensive care units at the hospitals. So we always need to try to reach this population, and it is important that there is no recommendation by PAHO to vaccinate with a booster children under 12.
Now, some words about monkeypox, and the Director General declared in July that there was growing involvement by people in monkeypox. So it became a disease of concern in the world. The vaccine is not the only measure. It is complementing other measures which continue early detection, and also following other public health measures and tracing contacts. So nobody has said to this point that there is an indication for mass vaccination against monkeypox. The advisory group of PAHO has said that vaccine should be offered to close contacts of people infected with monkeypox. So that's the group who should be offered monkeypox vaccines. And again, it's just a complement to other things. And you need to assess risks and benefits almost case by case. It is a different kind of vaccine when we talk about polio, measles. We have broad defined groups, but in that case, we're talking about mass vaccination of a cohort of children. But here, this is very specific, very particular. We also know that there is a limited stock of this vaccine and that it is very expensive. So we need to consider all of this. Post-exposure vaccine within 4 days of exposure can be considered by some high-risk countries. Thank you. Now, a few words about polio. Polio, we just said goodbye to polio in the Americas many years ago, but at this point in time, our coverages are low. You saw the coverages of DPT-3, 80%, polio, 79%. It's a little less, so it's worrisome. We have a group of children who could come down with polio if they are exposed to the virus at this point in time, and that is high. So see what happened here in the United States, and you've already perhaps participated in giving information about this disease. There was a man who had not been vaccinated and came down with paralysis. When you develop paralysis, it means that there are many infections around you, up to 1,000. So what this tells you is that there have been infections in that area. And also the other point in this case was that if you go to wastewater, you can find polio, and this means that it is circulating. This virus has been in the environment and is in the environment, and this also weighs, and it is also related to other similar findings of circulation in also circulation in the UK and Israel. So it's a very close virus that is circulating in other places. So 30 years, the Americas was the champion. We said, yes, we can. And we became the first region in the world to eliminate polio. But right now we're suffering because we have low coverages and because there is a situation where surveillance and the capacity of children to have sharp teeth and be out there detecting timely detecting suspect cases, this has also decreased, and this worries us, and it calls us to act more actively. Polio has no cure. Once a child develops paralysis, there's nothing we can offer them to revert that paralysis. It's permanent. But the vaccine is highly effective to prevent this paralysis, and it should be a full schedule, and it grants life protection. Once you complete your schedule, it is for life. We have had 2 countries considered high and very high risk of suffering from an outbreak. When we have one single case, you already consider it to be an outbreak. About 2 weeks, a resolution was passed at the end of September for responding more quickly, because we need to act quickly to defend that achievement and keep our region free of polio. Next one, please. And so this is my last slide, and I would like to emphasize that in order to have public health, to be able to improve the health of our peoples, the connection between information, health, and the community is key. And you, all journalists are important, very important to convey information as clearly as possible, as accurately as possible, as responsibly as possible, as in a timely fashion as possible. Without you, the communication with the community would be harder. Journalists participate in creating an opinion, informing an opinion, and you're partners in conveying information. So your role is defending the health of our communities, our peoples, and it is a significant role. And you also make decisions or you contribute to decision making by the population. What people see on the media is so clear that they will make decisions, very important decisions with respect to their health after reading or seeing something on the media. So you have an important, more than an important and heavy role to play to pass along information that is based on evidence. When we start passing on information without scientific evidence, or if we pass around an alarming piece of news, but which is not based on science. It is an irresponsible way to communicate. So it is important to communicate in a simple, timely way, accurate and based on evidence and facts is part of your important role. And we also praise those journalists who consult good resources, because resources need to be reliable. If media consult accurate resources, reliable resources, then of course that gives you clout with the people. So all these points that we have here are key, and they um, make a difference. So those of us who are trying to build public health hope that journalists and media fulfill that role, and all hopefully in a continuous manner. Thank you very much for your time. Thank you for being here. Thank you very much, Dr. Salas. Those of you who are just joining us, Dr. Salas is the head of immunizations here at PAHO. Thank you for your update on the vaccination situation and the situation of COVID and other regional vaccines. Now, to continue with our agenda, we're going to give the floor to Olivia Soar, who is a Director of Impact and New Initiatives in Chequeado. Olivia will talk about how there are information vacuums, the role of amplifiers, and how disinformation is spread about. Olivia, over to you. Yes, thank you. I was setting things up for my presentation. Thank you very much for this opportunity. I'd like to thank PAHO for the work they've been doing with us. And we started last year. Disinformation on vaccines multiplied and was circulating so fast. And according to what Dr. Salas was saying, journalists do have an important role to play, for better or for worse, in disinformation. This is why we think it's important to think about this and how we as journalists can contribute to minimize circulation and impact of disinformation, and specifically on health matters. So I'm going to start with a short introduction with some vocabulary, some terms. So for this, let me tell you who we are, who Chequeado is. We are a nonprofit organization. We started in 2010 working to improve public debate and fight disinformation. We maybe you have seen our notes, which is true, false, unsustainable, and all the other grades that we use. We also have other programs. We believe that journalism is essential to counteract disinformation, but it's not enough. That's why we have an education program, an innovation program, and an impact program here to let you know that Chequeado is based in Argentina. And so most of our work is here, but we also coordinate with other countries thanks to a network. It is called Latam Chequea, and almost all countries in the region have organizations who check information. They do fact checking, and so it is important to be a part of this network because it may have good resources for you. So now let us talk about disinformation. What is disinformation? There are many definitions and concepts around. So to be on the same page, when we talk about disinformation, we're talking about false or devious content which circulate, especially through social networks. There's also disinformation circulating in other environments, in rumors, on the streets, when we talk with our neighbors, with the taxi driver, with the people at the grocery store. And also through traditional media or digital media, we find this disinformation circulating, and also with, especially in social networks. It didn't start with social networks, but now it is a lot more powerful through social networks, because now you can have information spreading so rapidly like a wildfire. Also, when things are turned around, eh, this information is not in a vacuum. There is an ecosystem which leads to that disinformation being spread. There are anonymous messages and social networks. For example, in March 2020, when we got information circulating about how the virus had started, what were the symptoms, how you could transmit it, and what countries had it, there was so much information arriving. So it was bombarding us. And so in this context, it is very hard to separate what is information and disinformation. So it's harder to separate one from the other. In many of our countries, there is mistrust in the authorities, and some reasons justifiably, in others, not so much. But sometimes audiences don't trust authorities, and this allows disinformation to spread more quickly. And also there are what we call disinformation amplifiers. Also, disinformation uses sensitive topics and exploits prejudice, for example, with minorities, or also in gender issues. Also, matters such as xenophobia, things that happen in a society that may be biases, and they use these to make disinformation stronger. Disinformation can take different forms. In the end, we don't talk about fake news, because sometimes disinformation is not the news. It could be something that we see on WhatsApp, but we have different forms, which and this is something I wanted to mention. Beyond the different points, we not always have something that is absolutely false. Sometimes we have things that may be true, but that they are showing things that are, for example, a picture from a hospital that is circulating as if it were just 2 years, or things that show from a country, but it's another country. These are actual pictures that are given a false context, and they are made appear as something they are not. With WhatsApp, they tell you, "Oh, this is a doctor," but we really have no idea who that voice is, and we see this kind of content, which is modified from something that was true, but then it's no longer. So what are the possible motivations? And this is important, because if we want to have good strategies to counteract disinformation, we need to try to understand where this information is coming from, and who are the people who are generating it and sharing it. There are different motivations. One could be money. Disinformation is made to generate strong emotions and something to be shared quickly. So we are indignant, so we are angry. We have different strong emotions, and so we want to share things quickly. And sharing quickly is something that it can be monetized, and it can become money. So if it is monetized through publicity, etc., you can have a group of followers, and you can say, well, buy or sell from this person. So money can be also a motivation. Another motivation could be political. And in this case, for example, we can see it with some groups that are anti-vaxxers, that they are convinced deeply, and they then give disinformation. And also there is mistrust in some people. People can generate disinformation, and they present something as if it were part of the same thing. So we also see this not so much in those who generate, but in those who share disinformation, someone who is sharing information through the cell phone. And so you have pictures from your cousin and and issues from different pictures from your family, from this, that, and then you share something because you're just kind of in there and somebody sent you this, a family member, and you just pass it along. And I can share with you the rest of the material. We will have more material, and we need to understand who are these actors that spread disinformation and how they impact different places. There are also what we call the amplifiers. These are characters that may have different followers. These actors are people such as journalists. If we are not careful of the way in which we spread information, we can amplify this. So we can take something that was circulating in a small, closed network, and they will take them to a different area. And so we can go from small groups, and then they are amplifiers. And I would like to stop here, and now we can have questions, and I will give the floor to Florencia for the presentation. We can talk about the types of disinformation, how we saw it during the pandemic, and how it is linked to the vaccine, and how it can be applied to other types of information and disinformation that are circulating now related to health issues. Yes, thank you, Olivia. Now we're going to talk about disinformation regarding health. Disinformation about vaccines. We know that the phenomenon of disinformation is nothing new. We have many myths, a lot of disinformation circulating around, and they are linked to vaccines. Among the most widely known was a study in 1999 establishing a connection between autism and the DPT vaccine. And this study, even though it was retracted and clarifications were made, it damaged trust on vaccines. And this study is still circulating around, unfortunately. What we saw is that during coronavirus pandemic, there was a lot of disinformation about COVID-19 vaccines. The phenomenon of doubts about vaccination, about hesitancy, this had been called a threat, a public health threat, and it could jeopardize the achievements made with vaccination campaigns. Unfortunately, there was a lot of disinformation about COVID vaccines, and these rumors circulated over social media and many of these platforms, and this can erode trust in vaccines, not only COVID vaccine, but also other vaccines in general, vaccines that are part of the vaccination program of each one of our countries, which is why it is important to continue to dispel these rumors so that people can make decisions based on evidence and protect their own health and that of their family. As I said, or as Olivia was telling us recently, we are part of an organization called Latam Chequeado, which is a collaboration among different countries in the world. We have over 30 organizations in Latin America, and we verified this information which were related to pandemic. And in Latam Chequeado, vaccines was also specifically focused on COVID-19 vaccines. So it is very important to check around, and all the work we've done with COVID-19 vaccines is great. So the disinformation that was circulating in Argentina, and then they would go to Argentina or other Latin American countries. So we developed a list of the most common disinformation bits that were going around. So first of all, there is the disinformation related to vaccine development. For example, that the vaccine was just an experimental thing, that they were approved too quickly, and that this led to some doubts about their safety. And also disinformation that said the vaccines were not effective. This disinformation, for example, here, it is false that Pfizer marketed its vaccine without testing its efficacy. So this is the kind of thing we used to do. So this is false, and we would give it the false stamp. There was a question about whether the clinical trials had confirmed the effectiveness, and the person said no, for virus transmission, specifically virus transmission. So this answer was totally taken out of context, and this was used to say that somebody at the European Parliament had said that the vaccines were not effective, when the reality was that the question, as I said, was out of context. What the person had answered was that clinical trials were not done to verify or to test whether the vaccine could prevent transmission. No, that's not the point of clinical trials, but the clinical trials is to prevent symptomatic disease and to prevent deaths and hospitalizations. So you can see how an answer to one question, when you say no to that question, then it becomes disinformation because it is completely taken out of context. Also, we have disinformation related to the vaccine makeup. These are things that have circulated with other vaccines in the past, not COVID, that they have heavy metals, that and this was circulating through TikTok and other social media, that the vaccine could magnetize you and that people would be in danger, and if you put objects on your arms, they were magnetized, and also that the vaccines had microchips in them that would then allow people to follow you because you had that chip, or also disinformation about vaccines having graphene. So many of these pieces of disinformation are based on the fact that many times there is not reliable, accurate information. There is ignorance, lack of knowledge of how vaccines work. But vaccine components are public, they're open. People can ask what they have and they can learn what vaccines have. But since there is disinformation, since there is not reliable information among some groups of the population, then this becomes disinformation. This is why it is so necessary to have good information so that doubts are not generated. Also, disinformation related to how the vaccine works. Many of them have to do in particular with messenger RNA vaccines and the fact that supposedly they modify DNA or they can generate genetic damage. Again, ignorance about how vaccines actually work, especially how messenger RNA vaccines work, even though they are not new for the scientific community, but they were new for the general public, for the general audience, the population in general. So as journalists, we need to educate ourselves, understand how they work, and be able to respond people's doubts about them. That's part of our role. This one is very common and it's circulated in our region, and it has to do with alleged adverse effects and deaths related to COVID-19 vaccines, that the vaccine can leave you sterile, and that the vaccine has multiplied deaths in Israel by 40. So all these things are disinformation, and they are based on confusing causality and correlation. Sometimes you can have an event occurring simultaneously with another one. For example, I can get a vaccine and then I twisted my ankle. So to know that there is an actual cause-effect relationship, well, it's the vaccine that made my ankle be twisted. Well, you need to do research. So, I mean, there has to be a lot of research by the scientific community to establish a true correlation. But a lot of the disinformation is based on correlations, but not causality. So then we have all the information related to campaigns, to the vaccine campaigns, immunization campaigns on the field. Oh, that the syringes didn't have needles, or all these things, or some other myths that that said that, oh, it's better to have your own natural immunity than the immunity conferred by vaccines. So the immunity achieved through vaccination is more robust and persistent. And this, as journalists, we need to learn this and to spread that information. So and all of this outweighs the possible side effects that are usually mild and are resolved within 24 to 48 hours. So now the disinformation pieces that we saw, especially at the beginning of the pandemic regarding COVID-19, then went further, and they were combined with other diseases, and there were all these false links. For example, with the outbreak of monkeypox this year, people tried to make a connection between COVID-19 vaccination and monkeypox, or that COVID vaccine could cause monkeypox, especially related to the AstraZeneca vaccine, because they use as a viral vector chimpanzee modified DNA. So it's something that is completely innocuous. But since they had used the chimpanzee DNA in AstraZeneca, so people would link it to the monkeypox without considering that when you talk about monkeypox, it is a disease that is endemic in parts in Africa, and it has already caused outbreaks in other places much longer ago than the appearance of COVID-19. So now we have a situation of polio, which was described by Dr. Salas, and there was a resurgence of some disinformation that is related to the polio vaccine, which is related to some campaigns to booster polio. And this is happening in the Americas, and there are false links between the polio vaccine and cancer, and there's also conspiracy theories where Bill Gates is the bad guy, and these disinformation pieces says that the polio vaccine would be causing polio outbreaks in India, and so all of this is false.
So this is the most common disinformation in connection with vaccines in general, and also vaccines in connection with coronavirus. And now I give the floor to Olivia. Florencia, would you please turn on your camera so the participants can see you? I apologize. Thank you. Florencia Valadino, she's the editor with Chequeado. Thank you, Florencia. Olivia, we go on with you. So we change voices so that this is not, this doesn't become too long. So I just wanted to share with you some ideas that we have at this end as to how to prepare for the next information crisis and the next health crisis. Any new health crisis will bring along an information crisis. We continue to have the problems we usually have, and also the information problems we discussed before that we already know they exist. So how are we going to prepare so that next time we are better prepared and better suited to address this situation? We need to bear in mind that disinformation is here to stay, and it is not going to disappear. The solutions suggested are usually restrictive of freedom of expression, and they become worse than the problem itself. So it is quite likely that we need to get used to living with disinformation, and that our work is key in mitigating and counteracting it so that it has the least possible impact. But knowing this, let us see how we can prepare for the next time. I think it is key to analyze disinformation. It shouldn't take us by surprise. We need to see the type of disinformation that circulated during other crises. Unfortunately, we do know what type of disinformation was circulating during the pandemic. We do need to take advantage of that and better prepare for the next time and what type of information will circulate. We need to see what is happening in other countries. In some countries, information starts and then moves on to the next one. We need to see what is going on in those countries, the disinformation in those countries, so that we can prepare best when that disinformation spreads to our own, and see what groups may be most affected, who would be the most vulnerable to disinformation. And when we think about our work on vaccines, and we planned our work in 2020 to use it in 2021 with the beginning of vaccination, the elderly will may be easier victims of disinformation, and we may need to prepare a system to address disinformation targeting the elderly. And what happened, at least in our situation, is that because the elderly lived the pandemic as a crisis situation in a fearful situation, they were the ones who got vaccinated the fastest, whereas the most hesitancy was among the younger group of people, because they didn't think that COVID was such a high risk, and they even thought that disinformation or the alleged adverse effects would not have such a big impact on them. So we needed to work more with the younger people than with the elderly. So depending on the context and the crisis we face, our target audience as to the most vulnerable audience will change. One thing we may do is to fill the gaps whenever we need information. If there is something that is unknown, disinformation will take advantage of it. It doesn't mean that we need to know everything, but to produce evidence and to have good scientific evidence takes time. We do not want to contribute to the confusion, but we can say what is not known and why, and to be clear about the unknown, so that if someone says something about something that is not based on evidence, that is clearly understood. And we need to bear in mind the questions that our audiences, our communities have, and also try to fill the gaps with the most simple language in any format that makes sense. It is not useful to send a PDF file that is available somewhere. That is not going to fill a gap, something that is not easy to find and that is not speaking to the people who need it. Also provide tools to our audiences to search for trustworthy information whenever we go out to say that something is not true. For example, when Florencia was giving examples about the lack of vaccines, we can say this is fake because vaccine does not work in this fashion. This is untrue because it doesn't mean that because two things happen at the same time, there's a causal relationship. Everything we know to counteract disinformation, that in that way we can help so that the next time that information is faced with similar disinformation, that person has the tools to discard it, to ignore it, and also explain what is trustworthy and what is not. What are the trustworthy sources of information, and also make them available to people. We also need to know what type of disinformation is circulating. As journalists, we need to know what our audiences are discussing, the doubts they have, and also the disinformation that exists regarding what topics, in what format. Are these images, are those images that have been tampered with? That is to say, what is the type of disinformation that they have, and how can we counteract it so that we can create the tools for the individuals to know next time that something is not trustworthy? If there are several pictures that are circulating that come from a different country and they are not your own, you can look at the names on the street signs and also the car license plates to determine whether they match the ones in your own town or country, so that we can determine that something is false. This could be useful information for someone to have before sharing a piece of information. And it is also key to respond to the situation quickly. Here we need to strike a balance whenever we are going to counteract something that is not true. When something is so small that if we address it, we are going to enhance it, and we are going to become enhancers of a piece of information, even if it is to counteract it. And when something is relevant, when it is already circulating, when it has to be addressed. And the criteria that we need to bear in mind have to do with the viral characteristic of content. For example, if someone is using the traditional media, if it is something on several platforms, if it is something that is reaching to millions of individuals, we need to do it quickly. And the next aspect to take into account is how dangerous it is. So it would be dangerous if someone believes something, and so we need to participate. And also, disinformation travels very fast, and once it is spread, it is very difficult. It is more difficult to deny something than to act early. If we are able to find the information, the disinformation early, and we already see that it is reaching to a significant number of people, and that it is not something reduced, but it is something that is spreading, we know that if we can control it, those individuals who know that it is fake have fewer chances of spreading it. So we were able to curb the spread, but for that, we need to be on the lookout and do it quickly. And when thinking about the usual tactics used by those who misinform, something to bear in mind for us to identify those tactics, but once again, to alert, to warn our agencies that this is the type of strategy used by those who misinform, so that when they face them, they do not fall trap to them. On the one hand is the cherry picking. That is to say, they just choose whatever it is suitable to them. We see this, for example, whenever a paper had not even been peer reviewed and someone said, well, this proves my point, it doesn't matter that there are another 50 that say the opposite. So this is the fallacy of authority. For example, when it says that the Nobel Prize says so and so. And sometimes that Nobel Prize had not even said it, and it could be that that someone that was awarded the Nobel Prize may say something whenever something is beyond his or her area of expertise, but just to use this fallacy, this falsehood that because someone says something is true, that is incorrect. So also to make to take the correlation as causality and impossible likelihood, the impossibility. If something is not 100% safe or trustworthy, then we need to reject something. And this also applies to generalization or for example, my aunt had this problem and this is going to happen. And then also to use these general concepts as evidence. And when we're talking about anecdotal evidence, other strategies. I am not saying that this is true, but I wonder, wouldn't it be possible? And then they just publish some disinformation. We cannot check a question. We cannot say that the question is fake. We can say that the question leads to something that is false, but that also turns to a more difficult situation because it is presented in a deceitful way. And the same as to create the same goes for conspiracy theory and also the use of these theories by people who misinform. And also when we assess what to do in terms of disinformation first, what is the risk of believing in that misinformation? Could there be a direct risk to health, to life? We also need to look at the viral aspect of disinformation, how quickly it spread, and also, if possible, to counteract the content. If this is circulating over WhatsApp, let's use WhatsApp to counteract that information. Let's use the same platform that this information is being spread on. And also think about the type of content needed to deny something, and also how to reach to those individuals that had access to the disinformation. And throughout the process, we need to do it in the most empathic fashion. Those who believed in disinformation maybe did it because they were sharing something that was useful. We need to be empathetic, and we also need to convince them with the best possible arguments, with transparency and clarity in terms of the information we have, so that the next time they find similar content, they do have the tools to address it. And with this, I give the floor again to Florencia for the last portion of this presentation. I thank you, Olivia. And to conclude, the idea is to offer some advice as to how to communicate in connection with vaccines with responsibility. And I would like to thank the Association of Vaccines and Immunization from Argentina, because many of the pieces of advice we received were the result of the communication and what we see on a daily basis. In principle, I should mention that the information on science and health should be clear, brief, and evidence-based, and we should always, as journalists, resort to qualified and specialized sources. We should also avoid technical words. Whenever we introduce a highly technical word, we are distancing ourselves from the reader, from whoever is reading our piece or listening to us on the radio. So we need to try to define and use the most concrete possible terms to reach out to a broad audience. I was also saying that we need to consult with specialized sources and also issues that go beyond their academic training and professional experience, what we may call as being intrusive and intrusiveness. Whenever there was an attempt to discuss, for example, coronavirus, the experts were not consulted, be it vaccinators, people, infectologists, and pediatricians when we were talking about children. Rather, other specialties that were not related to vaccination and who were not the right experts to talk about vaccines. We saw this with some associations such as epidemiologists or Doctors for Truth that were misinformed and talked about COVID causing a lot of harm. And many of those individuals were not specialized and they were not even certified to be able to talk about this. And some of the questions we may ask is, who does this person work for? Does he or she have a license? Does he or she belong to any professional association? Was he or she a member of a scientific association? Did he or she publish any document, scientific document? Was he or she recommended by another source that is trustworthy? And once again, do not just believe what one voice, one expert says, but believe in experts, plural. And as Bolivia just mentioned, that voice it doesn't matter if that voice will ever receive the Nobel Prize. And also, we need to remember the vaccination is not an individual process, rather a collective process. We should not be basing this on just anecdotal evidence or personal cases. We also need to be trustworthy, meaning that we need to prove the origin of the information and clearly identify the sources that are used, be it health authorities, academic institutions, or the pharmaceutical sector. And we also need to bear in mind content that provides information on adverse events and clearly differentiate between causality and correlation, and vaccination may not be the cause of some of those effects or events. We should also foster discussions or exchanges between two voices. We should also avoid false equivalency between quality scientific evidence and unsupported or unfounded opinions. And also, given a scientific paper, we should ask ourselves, where was it published? Who are the peers? Who is financing the investigation? Was it peer reviewed? And what are the limitations to the conclusions? These would be the most important questions every time that we are faced with a new scientific paper as journalists. We should also be cautious with the so-called magazines that do not have the endorsement that they usually should have. Sometimes they do charge scientists for them to publish their own papers. They are not of any significance. Oftentimes they are fraudulent. The name is similar to that of recognized and well-known magazines or journals, but it is not that one. The most common one is Bell List. You can go onto the web and make sure, check there whether a journal is a trustworthy journal or not, or it is one of these publications that has no value. And also, you need to bear in mind that some preprints are not clear as to whether the conclusions or the findings were trustworthy. And also you need to include the opinion of an independent scientist who may say whether the study is contributing something new to the field or not. It is also important to provide context. It is important to think that numbers in themselves need to be given in context. So statistical data is necessary so as not to lead to false information. And something that we saw a great deal is the paradox, the Simpsons paradox. You could see how there was some information that indicated that there were more vaccinated individuals that were hospitalized than unvaccinated ones hospitalized. And this is similar to this analogy. If we think of a road accident, if we think that 50 individuals died who did not carry a seatbelt and 950 had a seatbelt, what is the clear relationship? It is not clear, the difference, but this is a result of the fact that when we analyze information together, the result is different than when we analyze just the subset. If we look at the subset, we see that 50 out of the 1,000 did not have a seatbelt, 35 died, close to 70%, and those who had a seatbelt were 950 individuals. That is to say, most, and only 11%, 110 died. It is also important to bear in mind that the image conveys a message. The pictures, for example, do have an emotional impact. We need to avoid images showing children crying or large needles with a colorful liquid, because that may predispose to rejection. And I am always asked how to continue to talk about vaccines when individuals are not interested in vaccines. How can we maintain the attractive nature of the subject matter? I think that we need to look at the world around us. We need to have interesting approaches for these vaccination campaigns with precision. And here I would like to show some stories that I thought were nice and that I put together during the pandemic, as you see on the slide. So I would like to thank you all for this opportunity, for the presentation of the guide, and we will be happy to answer any questions you may have. Thank you. Thank you very much, Florencia, Olivia, Dr. Salas. I would also like to thank those who sent us questions and comments. Ariel Javier Faracosta from Paraguay, Javier Stegman, Blanca Valadez, Francisco Weber, Linda Straken, and Luca Villar, who sent us questions and comments. I would like to share with you Violeta's comment. Violeta is saying that the COVID-19 crisis is also the media crisis. And she's saying with fewer journalists, fewer media, makeshift situation and the lack of public policies to support the media as a way to strengthen the democracy, which this would lead to a complex situation. On the other hand, we should also recognize that disinformation happened, that doctors and scientists decided to move to the other side of history, and they got vaccinated about getting vaccinated, and that led to doubts among the population. She's also saying that at the outset, the media gave room to dissenting voices, or they allowed dissenting voices to express their opinion, but thank God we have made some progress. I would like to say that the crisis did start before the COVID-19 pandemic. Those of us who do not usually cover scientific issues had to rush to learn about science. We were not good. Not all of us were good. And we may have contributed to the confusion, because from covering the economy to politics to become experts in vaccines is not something that is that easy. So I would say that the media had to restructure itself, and this did not happen instantly, so it didn't help us improve the situation, to give the voice not only to dissenting voices, but those who were representing the minorities and were not evidence-based. Is related to what Flor said. We have to remember that there are two sides to the story. We need to see where the evidence is and is not, and also the fact that even though people may have some sort of relationship to something or someone, doesn't mean that they are sharing evidence or the truth. I don't know whether Flor would like to add something to this. Thank you. As Olivia mentioned, we have more comments and also appreciation. And as to the recording, we will be sharing the recording and towards the end. And we will also ask you whether you can share this with other colleagues that may be interested in this. We thank you. And also if you can share the guide and the link to the guide. So we are coming to an end. I just wanted to repeat something of what Olivia said in one of the presentations. Olivia, you said that disinformation is here to stay, but that we can minimize it. And we hope that with this workshop and the guide, we can contribute to that. We can contribute to give you some tools, give tools to the journalists to strengthen their coverages and also to give better information to people without causing any harm. That's all. I thank you all again for connecting today, and we continue to be in contact. You can reach us here at PAHO. Media team at paho.org is available to you to reach to us, and also with the people here from Chequeado. A pleasure to see you, and see you next time.